Okay. Thank you so much for the introduction and very good afternoon to all of you. First of all, my sincere thanks for this invitation, really. It's an honor and a privilege to be here. Particular thanks to my batchmates, Vatsala and Hemal, for the invitation. I just couldn't say no to you. And so thank you for having me here. And actually, feel very honored to be speaking at the end of a long lineup of very sort of esteemed speakers. Okay, so I was asked to speak on this topic, physical comorbidities in psychiatric illness and vice versa. So I prefer to call it the mind-body interface. And I think hopefully I can give you some important take-home messages. So what we'll be talking about today is how do physical and psychological disorders interact, and what's the evidence? What's the evidence for their impact on outcomes, patient outcomes? And then finally, what can we do as physicians, as surgeons, as psychiatrists, as pediatricians, obstetricians, to create practical, integrated models of care for our patients. And I also understand that I stand between you and the tea, so I will stick to time. Right, now, last week, this made headlines in CNN because the church, the Catholic Church, was showing a lot of resistance to treating certain patients at hospitals. They were anti-gender related patients. So the Catholic hospitals were very much against patients who were bisexual or gay or transgender receiving care at hospitals. So what I'm trying to point out is this is not the first time that religion has interfered or caused certain resistance in treatment of patients. If I take you back to maybe 3rd or the 4th century, illness was seen more as a spiritual connection, like a punishment from God or a test from God. And so healing was more spiritual. So there were no doctors involved. It was sort of by monks and other people involved in religion. They were the healers. And it was care. So it was like homes and places of worship were offered to patients to recover. And there was not much focus on cure. Medicine or surgical interventions were not very much practiced because there was a lot of resistance for invasive procedures. Because the moment you interfered with the body, it was seen as an interference with the soul. So there was a lot of resistance against this. But sometime later, do you know who this man is? He's a French philosopher called Descartes, or Descartes, but it's pronounced Descartes. So what he did was, to overcome this problem, he separated the mind and the body. So that allowed physicians, surgeons to do their work on the body. So he explained to the church, he said, look, the body is just a machine and the mind is separate. So let the physicians and let the surgeons do their thing on the body. So because of that, you call it the Cartesian divide, dividing the body and the mind, right? So that allowed people like us, the surgeons or the medical people, to go about treating the ill people. And this was the famous dualism in medicine. So that was the start of dualism. But what happened with dualism then was that it sort of created these two paths. So psychiatry is different from medicine. Or you have organic disorders and functional disorders. Sometimes we use these terms still. Because this concept of dualism is very prevalent in Asia, not only in Sri Lanka, right? There's a lot of focus on the biomedical side in undergraduate teaching, right? And we also deal with heavy loads of patients. So there's not really much time for you to address the emotional needs or assess them. And still there continues to be a lot of stigma around mental illness. And then, of course, you prioritize physical over psychological, even us as families. And then phrases like, oh, this is psychiatric. This is psychiatric. and it's a psychiatric patient. So we see these on BHTs, isn't it, right? So whatever the patient is having, psychiatric patient is written first, right? So this is a very commonly seen thing in Asian hospitals. So later, some years later, there was this famous American physician, George Engels. He's the one who said, look, this is wrong. And it's not two separate things, okay? It's not just cells and diseases, we're treating people. And due to this sort of breakthrough statement and the studies and the work that followed Engels, you discarded Descartes and you went from dualism to integration. And in support of this, there were several studies that came out, right? There were brain areas identified, then the role of stress in illness causation, how the mind-immune links work, then neuroimaging, and then I think previous speakers spoke about the biopsychosocial model. So it's not just biological factors, there are psychological factors and social factors coming. It was Engels actually who explained this. And then of course epigenetics, you have heard of the evolution of epigenetics, how experience alters gene expression. We particularly see this in schizophrenia, in PTSD. So this sort of led to the killing of Descartes, as it were. And of course, very recently, these articles are from a couple of years back in reputed journals, right, where people have looked at diabetes and depression, right? Then the impact of treating mental health problems in patients with ischemic heart disease, then anxiety and depression, the impact of depression and other psychiatric problems in Parkinson's, co-occurrence of mental illness and physical diseases. I think that was a very recent one. And of course, this famous brain-gut connection. These studies very, very strongly support the notion of integration rather than dualism, right? Now, if you look at illness, mental illness across the globe in people, this is from a few years back. But if you look at Sri Lanka, we are somewhere in the sort of the dark orange area, which is about 15% prevalence of some sort of mental illness. The commonest things are anxieties, depression, things like that. So we need to be aware. I'm not here to convince you all that psychiatry is the most important thing. But remember that there's a huge comorbidity in medicine and mental illnesses. So you need to remember that. And in 15% of patients in your wards, they will have some sort of psychiatric problem as a comorbidity, maybe not a primary diagnosis, right? And you need to be a little bit familiar with some of the common psychiatric disorders. Depression is by far the more prevalent one. Anxiety disorders, you will see perhaps less of schizophrenia, but you will see bipolar and so many other illnesses. But let's focus on the more important ones, so to make sure that we don't miss anything, okay? Now, if you look at depression, again, very common in South Asia, very common in Sri Lanka as well. Unfortunately, women are more vulnerable to develop depression. There's a genetic component. It's a multi-pronged contribution from many factors contributing to depression. And depression is not just feeling sad. Depression is not just crying. It's an illness with a cluster of symptoms, right? And we need to be familiar with the low mood, sleep disturbances, eating issues, lack of energy, lack of enjoyment, pessimistic, negative type of thinking, right? Thoughts of reduced self-worth, so much so that it sometimes leads patients to take their own lives. So you're familiar with this. This was just a refreshment of the facts. So depression, the problem with depression is, if you look at post-MI patients in your wards, right, about 20 to 30% of post-MI patients will have clinically significant depression. And that causes a risk of mortality by 1.6 times and 2.4 times higher cardiac mortality even after adjustment. This is coming from very latest data. This is what depression does to you, right? If you look at diabetes, there's of course a bidirectional link, right? It increases the risk, depression increases the risk of diabetes. So our patients have a higher risk of developing diabetes. And diabetes doubles the risk of depression. Right? So there's a clear bidirectional link, and of course when you have depression comorbid with the diabetes, it brings worse glycemic control and more complications therefore. If you look at cancer, this is all causes, huge range of increased risk in mortality. If you look at stroke, post-stroke depression, about 1/3 of your stroke patients will have post-stroke depression. Of course, it depends on the area affected, but in general, it affects about 1/3. And of course, that indicates poor functional recovery and of course leads to higher mortality. So it's a combination of inflammation, HPA overactivity, and various other mediators coming into play. But I've focused on some of the very more prevalent and more common illnesses so that you will not forget this, the importance of picking up depression in your patients. Okay, so the takeaway for depression is that depression will not only improve the psychological well-being, but also the physical recovery and prognosis of your patients in your wards. Right? The next common one is anxiety. Most commonest condition that you will see in adults, even in children we see anxiety. The problem with anxiety is you will see more patients with anxiety in COPD patients, right? Asthma, thyrotoxicosis, hypoglycemia, these patients you will see significant amount of comorbid anxiety. And then because there's a little bit of an overlap with the symptoms, it's often misattributed to the original physical illness because of the palpitation, the tremors and all of that. So it's missed, right? And with COPD, if you have comorbid anxiety, it increases exacerbations, hospitalizations, mortality and all of that. Have you heard of fear conditioning? So fear conditioning is being fearful of something. So you're fearing an exacerbation of your COPD, and even if you don't have a COPD exacerbation, the fear of thinking that you may get it sort of sets off a vicious cycle. So that is what fear conditioning is. So your brain learns to be scared of something because it gets paired with something dangerous. If I get an exacerbation, I will be hospitalized or might die. Right? Okay. This is another important area you need to be aware of. Adjustment disorder and psychological distress. It sounds very fancy, but what it's saying is your patient adjusting to being told that they have a very bad diagnosis. That is what adjustment disorder is, right? So that is why we are very careful, we are very concerned about how sensitive the issue is when you break the bad news to the patient, adjusting to the new lifestyle that this illness brings with it, right? So particularly in cancer, renal failure and various perioperative complications, those contexts, be mindful of this adjustment disorder. Okay, I'll tell you what it looks like, but let me just take you through. So in about 50% of patients who are newly diagnosed with cancer, signs of distress. This doesn't mean they are depressed, doesn't mean they have an illness. Distress is not a clinical diagnosis, it's a symptom cluster that shows discomfort, difficulty adjusting to this. So it will manifest as sleep issues, pain threshold goes down, poor immune recovery, poor adherence to treatment and any sort of management plans that you set up with the patient. So keep that in mind when patients first hear of this diagnosis being given to them. But like it was mentioned in I think some of the previous lectures, things like counseling, talking to the patient, allowing them to ventilate how they are feeling. If you're fortunate enough to work in a unit where you have therapists, CBT, relaxation, and giving them time to adjust to this, right? Without overlooking these symptoms as patients being very difficult. Okay, harikaradara, nuisance. Yes, when patients are distressed, when they are anxious, when they are depressed, they are very difficult. They can be very difficult. They are moody, they get angry, right? So then when we are running busy clinics and wards, sometimes it's very difficult to tolerate this. I completely understand, but be mindful of this. Now next, I want to talk to you about our patients. So when psychiatric patients get physically ill, what's the scenario there? Now this was a very recent study, not recent, but a couple of years back. And what they have said is when mentally ill patients have physical multimorbidity, it's very, very important to have a multidisciplinary approach, right? And it's also important to recognize, I think, that they are also human beings. Yes, they may be having depression, they may be having bipolar, they may be having schizophrenia, dementia, and they are very difficult patients, right? But that does not mean that they can't develop other illnesses, and we have within our practice, we need to be attentive to that and sensitive to that, right? So the suggestion is a multidisciplinary approach for those with severe mental illness, and physical multimorbidity is the recommendation. And I'll talk a little bit more about this. Severe mental illness increases the physical health burden. So patients with schizophrenia or bipolar have a higher chance of cardiovascular disease and infections. It may be due to medication. You know that antidepressants, antipsychotics are full of side effects, weight gain, metabolic symptoms are common, their hygiene is poor, so they may be having infectious diseases which they pass on to other people, and things like that. So an integrated model is highly essential when it comes to the psychiatric patients who develop physical health problems. Right. And now what happens is, when you don't recognize the mental illness, when you fail to pick up the depression, when you fail to pick up the anxiety, when you fail to pick up the distress in patients, it undermines the efforts that you put. You put so much effort into your patients, but there is an underlying psychiatric illness that is preventing your patient from reaching full recovery, right? Because when mental illness goes undetected, right, patients will miss appointments, they will skip their medication, they will therefore have all the other unnecessary complications, poor blood pressure, poor glycemic control, and all of that. And then they come late with advanced disease. And then, of course, more complications. And they are less likely to receive guideline concordant treatment. So when they come later with a lot of complications or advanced disease, they are very likely to not receive the ideal treatment. And so this goes in this sort of vicious spiral, and you lose the patient simply because you fail to pick it up at the initial stage. Hope it's clear. Right. So this is one of the major contributors to the excess mortality. Now, what happens is this, have you heard of diagnostic overshadowing? So we sort of feel that we are sort of still a little bit in this Cartesian divide, and we sort of, the moment a patient is psychiatric, you separate that patient out. Or the moment your MI patient has some psychiatric thing, you disregard that. So it's very funny the way it works, right? Sometimes in our own wards, in our own hospitals it works. So that is called diagnostic overshadowing. We fail to recognize that this patient can have two diagnoses, right? So therefore patients, the ideal optimal treatment is missed. So this is a huge system level danger, and physical symptoms in mentally ill patients are dismissed as psychological. So you have a schizophrenia patient who is showing signs of a physical illness, but you think, oh no, this is schizophrenia, so it can't be anything else. This is part of the schizophrenia. right? So you miss MIs, you miss strokes, you miss sepsis, cancer diagnosis, late surgical intervention. Studies have repeatedly shown this. Unfortunately, this is high in Asian countries. Still, it's better than what it was, but it still remains high for all-cause mortality in psychiatric patients, right? It is one of the biggest contributors to mortality in the psychiatric population. So, a little bit leading on a little bit towards beyond that. So, what happens is that if you fail to recognize mental illness in physically unwell patients, this is what you should remember. If you fail to recognize mental illness in the physically unwell patients, you increase the risk of death by about 5 times, keeping in mind how common mental illnesses are as well, right? So, I mean, the training that, when we were final year students, we didn't have a final year appointment in psychiatry, but now all medical schools have a final year appointment in psychiatry, and we see more and more young doctors who are very adept, very well able to pick up the clinical signs, and please make the necessary referral and do the needful, the just thing for the patient, right? So, remember, it will increase the mortality by 5 times. So, please remember that in all the major medical conditions, failure to pick it up, right? So, it is not an option. You need to be very sharp and pick up this if you want to reduce mortality in the physically ill patients. Because like I said over and over again, the poor adherence, late presentation, all of that can be avoided. And don't forget, treating the mental illness will have a significant impact on the quality of life of your patients and for us as well, right? So, please remember this. These are all of the information that I have given you here is driven by facts, research and numbers. So, try to adhere to that when you next practice. And with that, let me just conclude by saying, again, George Engel, famous physician, stroke psychiatrist, there were no separate psychiatrists during that time. If we don't address psychiatry related factors, we are treating only half the disease and expecting a full recovery in our patients. So, please keep this in mind when you next see a patient. I'm so glad the speakers before me mentioned things like empathy. Smile, start with a smile. Show empathy. Don't forget that this is also somebody's mother, somebody's father, somebody's sister. Treat the patient like it's somebody of your own. That makes a huge difference in the way you approach the patient. And here you have psychiatrists who are very good clinicians, colleagues of mine. Don't hesitate to liaise with them. If you have any doubt, you may be wrong, you may misdiagnose depression, you may think it's anxiety, but that's okay. Being overcaring, overcautious about diagnosis is better than missing it completely. So, please refer to colleagues and don't stick to this old sort of archaic terms of stigmatizing patients, psychiatric patients, schizophrenia patient and things like that. They are also people and they also will fall in, and there will be so many in your wards. And then the other message that I want to tell you is, remember the overlap of the major illnesses: myocardial infarction, stroke, diabetes, other endocrine problems, COPD, asthma, the overlap with depression and anxiety. Please don't forget that. And make the call and refer the patients accordingly. So, once again, thank you so much for this invitation, and it's an absolute pleasure to be here at this inaugural event. And I hope that you take away at least a little bit of the information that I have thrown at you. Thank you so much.